Okay, so let's talk about some issues related to coronary artery disease. So, when we say coronary artery disease, we mean atherosclerosis and the buildup of plaques within one or more coronary arteries. And as plaques get bigger and bigger and bigger within the lumen of the coronary arteries, they restrict blood flow. And when they restrict blood flow in the coronary arteries, the patient gets symptoms, right? Because the coronary arteries are responsible for feeding the heart with oxygen and glucose. So, so we want to know if there's significant blockages of the coronary arteries that are causing this person's chest pain or shortness of breath, right? So so coronary atherosclerosis is by far the most common problem that we're going to be talking about in the coronary arteries. So plaque formation that gradually builds and builds over the years until it occludes or begins to occlude the coronary artery. And as it occludes the coronary artery and reduces blood flow, a patient may have stable angina. So stable angina is, I don't have any symptoms at rest, but when I go for a walk up a hill, I get chest pain. Why? Because walking up that hill, my heart needed more blood flow in the coronary arteries to provide more oxygen and glucose, and it was unable to get it because of a coronary artery plaque or occlusion. Okay, but it's stable. So the plaque's not getting bigger, it's just staying the same size, and usually the patient has predictable symptoms at a certain level of exercise. In fact, some people come in and say, when I walk up a certain hill at home, I get chest pain. And when I sit down, it goes away within a minute or two. Okay, so that's stable angina. Very predictable, and it's from a fixed occlusion in a coronary artery. It's not completely blocked. It might only be 50 or 60% blocked. And the symptoms occur with exertion. So we call it exertional angina or stable angina. Okay, everything after stable angina, we're going to put under the umbrella acute coronary syndrome, ACS. Okay, because they're more critical. Okay, they're on their way to causing much more damage. So unstable angina is where the plaque, say the person had stable angina for a few years and everything was fine. They'd walk up a hill, they'd stop, they'd take their nitroglycerin after sitting down, and it would disappear, and they'd continue on until it happened again. Very predictable. Unstable angina is where the plaque is blocking much more of the coronary artery, okay? And so it might be 90% occluded or 95% occluded. So now their angina has become completely unpredictable. They have pain at rest. They have chest pain sitting at the dinner table. They have chest pain while sleeping. So the frequency of the chest pain has increased and it's become unpredictable. And they have rest pain as well. Okay, so it's not that stable angina anymore. It's become chest pain throughout the day, unpredictable, and what it's telling us is, ooh, that coronary artery is becoming critically occluded. How do we know it's unstable angina and not a heart attack? Troponin. Unstable angina will have a negative troponin in the blood. There's been no myocardial infarction. Okay, it's still very important, and it still needs hospitalization. It's just that there hasn't been a heart attack yet. Okay, sometimes we'll see it on the ECG. We often get it from the patient's history, and the serum troponin is negative. Okay, myocardial infarction. So myocardial infarction, by definition, by what it's saying is there's been a heart attack. There's been an infarction, which is myocardial cell death. And there's going to be release of troponin into the blood. So in a myocardial infarct, you are going to have elevated troponin. There's two types. There's an NSTEMI, which is a non-ST elevation MI. And so now we're talking about how it looks on an ECG. So there's heart attacks that don't have what's called ST elevation, and we'll call them an NSTEMI because they have a positive troponin, and a STEMI. So ST elevation MI, on an ECG, we can see a STEMI because the ST segment is elevated and they have a positive troponin. Okay, we'll get to those terms in much more detail in the following module where we look at ECGs. Okay, so an NSTEMI is a critical occlusion of a coronary artery where there's just not enough blood flow getting through, and part of the myocardium is starting to die. Okay, and it's releasing troponin into the bloodstream. They've had a heart attack. An NSTEMI is usually, so where does the myocardium start to die when you have an NSTEMI? It's the muscle closest to the chambers, what's called the subendocardial muscle. Okay. Whereas in a STEMI, we call it a transmural MI. The entire thickness of the muscle of the heart has been affected in a STEMI. Whereas in an NSTEMI, it's usually just the muscle that's closest to the chamber where the blood is being pumped. Okay, so a subendocardial MI. Okay, a STEMI is complete occlusion of a coronary artery, no blood flow at all, and the entire thickness of that part of the myocardium is dying. Okay, so part of it is already dead, that's why it's an infarction, and if not treated, more of it will continue to die. That's why it's so important to open up the artery, the coronary artery, in a STEMI. Okay, to get that blood flowing to the area that's dying. Okay, so let's look at the coronary arteries. So you have to go up to the aorta, or just follow back these coronary arteries, and you have a right coronary artery that's going to wrap around the right ventricle, and you have a left coronary artery. Both of them are going to come off of the aorta. And what's their purpose? To feed the heart with oxygen and nutrients, right? Every organ in your body needs arteries to feed it with nutrients and oxygen. Okay, so the left main coronary artery, or the left coronary artery, branches off into there's a large branch that goes down the front of the heart called the left anterior descending artery. And the rest of it wraps around the left side of the heart called the circumflex artery. The left anterior descending artery is a pretty important artery because it feeds the left ventricle, the major pumping of the heart. And when that gets blocked, it's a pretty big deal. Some people don't survive a complete occlusion of the left anterior descending artery, or the left coronary artery for that matter, because it's feeding the left ventricle, and if the left ventricle dies, well, the pumping is not good. Okay, so that's the anatomy. So left and right coronary artery. The left coronary artery becomes the left anterior descending, and the other branch of the left coronary becomes the circumflex that wraps around the left part of the heart, and the right coronary artery that feeds the right side of the heart, and also it wraps around the bottom of the right side of the heart. Okay, so let's talk about coronary artery atherosclerosis. Remember, atherosclerosis is an arterial disease that happens all over the arteries in your body. So you could have cerebral artery atherosclerosis, renal artery atherosclerosis. You can have peripheral vascular atherosclerosis to the arteries to your legs or to your arms. So it's not usually isolated just to the coronary arteries. I know that's what we're talking about today, but remember, it's an arterial disease. Okay, so it's typically not just isolated to the heart. Okay, so let's look at the image on the right. Okay, so there's a healthy artery at the top. The inner layer is the endothelium. It's like a saran wrap. It's a very thin lining that allows the blood to flow, but not stick to it, right? So it's made so that the blood recognizes it as normal and it doesn't cause clots or plaques or anything on it. And over time, there's some kind of an injury to the endothelium. That could be inflammation within the artery. That could be toxins, cigarette smoking, hypertension. Some kind of injury that has occurred over years is now injuring the endothelial lining. And you're starting to form plaques. And usually at the beginning, the plaques are minimal. They're what are called fatty streaks. Okay, and fatty streaks can be seen in teenagers in early 20s. Okay, depending on whether they have hypertension, diabetes, their diet, exercise level. Okay, any of those things will impact the arteries. And after minimal streaks, you start to get small plaque formation. And what's in the plaques? Well, there's usually inflammatory cells and lipids and fats and cholesterol that are depositing in the arterial wall. Okay. Now, there's still an endothelial lining. Okay, so if you look at the third image, there's still an endothelial lining where the blood is flowing across. And as the plaque gets bigger, so image number 4, filled with inflammatory cells and fat and lipids and cholesterol, it's starting to block more and more of the lumen of the artery. And in this case, we're talking about the coronary artery. And it's forming a plaque that's going into the lumen of the artery. So it might be just 10% blocking the artery, or 20%, or 30%, or 80%, okay? So it's forming what's called a fibrous plaque. Now, trouble starts when that plaque ruptures, and all the stuff that was inside the plaque now squeezes out. And what happens is the blood now recognizes this stuff as foreign and attacks it, and it forms a clot on it. So not only do you have a clot rupture, a plaque rupture, but you have clotting happening on the plaque rupture by the body's natural clotting ability. Okay, so someone may go on for years and have plaques, and they may have a stable plaque, which will form angina, stable angina, right? Predictable angina. And then one day that plaque ruptures. So it suddenly ruptures one day, fills the coronary artery with the stuff that was in this plaque, and suddenly the blood is clotting on top of it because it wants to stop it. It sees it as foreign. And you have suddenly coronary artery occlusion. And that's what leads to unstable angina, an NSTEMI or a STEMI, or if it's complete occlusion and the heart just stops beating, well, cardiac arrest. And cardiac arrest means no pumping of the heart. Okay. So again, The cholesterol is really just a long-term risk factor. I know it's listed there. It's just a long-term risk factor. So high LDLs and low HDLs are just a risk factor for this process to occur. Just like smoking is a risk factor, just like hypertension is a risk factor, and diabetes and family history. They're all just risk factors. So don't see cholesterol as, oh, this is the worst risk factor. No, smoking, family history, diabetes, they're all risk factors for this process to be accelerated. Okay. Okay, so here's the risk factors. I didn't need to mention them on the slide before. So smoking, why does that cause coronary disease? The toxins in the bloodstream, damaging the arteries and accelerating plaque formation, just like the rest of these. Hypertension, same thing, damages the arteries. Hyperlipidemia, which is high cholesterol levels, same thing. Diabetes damages the blood vessels. Okay, but the high sugar content in the blood is damaging the vessels and leading to atherosclerosis, type 1 or type 2 diabetes. Obesity, obesity often leads to hypertension and hyperlipidemia and diabetes, so it's a risk factor in itself. Family history and your genetics is definitely a risk factor, okay? Your age, so the older we get, the more chance that we've developed more coronary artery disease. Race can be an issue, and inactivity. Okay, so a sedentary lifestyle where the coronary arteries don't receive lots of blood flow during exercise, that can lead to atherosclerosis in many of the arterial beds, not just the coronary arteries, but others as well. Okay, so really the prevention is change the risk factor, change the modifiable risk factors, right? Smoking is modifiable, hypertension is treatable, hyperlipidemia is treatable, diabetes is treatable, obesity is treatable, inactivity is treatable. So many of these are modifiable, some of them aren't. Family history, age, race, not modifiable, right? Okay, so let's move on here. Okay, so angina pectoris or angina is episodes of chest pain, or some people describe it as chest pressure. And what is it? It's inadequate oxygen supply, but increased demand. So I go for a walk, I'm going up a hill, my heart's beating faster and harder, I need more oxygen, but the coronary artery is somewhat blocked, it can't provide more flow. So the demand from the heart for more blood is there, but the supply can't be increased. What do I get? Chest pain, right? So ischemic chest pain. Okay, and then I stop, I feel better. So the demand has gone back down to normal and the supply has remained the same. Okay, so two types, stable angina is totally predictable. It's totally consistent with a certain amount of exertion, and then it's relieved by sitting down and resting, and even taking nitroglycerin. Okay, some people don't take nitroglycerin; they just sit down and rest. But many people have nitroglycerin. They can put a tablet under their tongue. It'll also relieve the pain of angina. Why does it relieve the pain of angina? Well, it can vasodilate the coronary arteries and help a bit more blood flow to get through. And it also reduces blood pressure because it vasodilates the arteries. And it also vasodilates the veins, so it reduces more blood from returning to the heart. So it's basically just taking the workload off the heart. Less blood returning, lower blood pressure that the heart has to pump against, and on top of that, it vasodilates the coronary arteries. Okay? So what's it from? Atherosclerosis in the coronary artery. Is it a critical lesion? No. It's a lesion that's big enough that when you go and exert yourself, you get chest pain and then goes away. Some people describe it as indigestion. Some people get it in the epigastric area of their abdomen. What do? Well, we've obtained the patient history. We're going to get a 12-lead ECG. We're going to do labs, especially for troponin. And also, we'll get a CBC because we want to make sure that the patient's not anemic. Remember, if you're anemic, you're not carrying enough oxygen to the heart, and that can give you angina. Rarely, but it can happen. And then with angina, if it's new onset angina, we may set them up for an exercise stress test or a nuclear stress test. Or if we think it's really severe angina and the patient has symptoms at very little activity, or if it's unstable angina, we're going to set them up for a cardiac catheterization to look at their coronary arteries. Okay, so they may need a percutaneous coronary intervention where they look at the coronary arteries and then they have the ability to either perform angioplasty to open up the blockage and put a stent across it.